Danny Villano is going to be running this remotely. So just bear with us for a moment.
Thank you. And thank you to Biogen for inviting us to speak on this really important and emerging topic, which is, the transition process from a pediatric setting to an adult setting. For those of you that don't know me, my name is Danny Villano. I'm the neuromuscular nurse consultant at the Royal Children's Hospital. I've been doing this role at RCH for about 15 years. And my role really involves assisting in managing the clinical and the research program, neuromuscular program at RCH. It's a wonderful place to be and with a wonderful team. So today's presentation, I'm just going to do a bit of an introduction on what transition is and the way that we do it at RCH. And then we'll talk through a best case sort of scenario that we've experienced at RCH. And I've got a panel with me who's going to help me along with the discussion. So Dr. Epiu is a paediatric neurologist at RCH who's heading our neuromuscular program. The wonderful Robin Forbes, who you've got there with you, is our genetic counsellor and really expert on a lot of things in our service. And we're really lucky to get to work with Associate Professor Lauren Saunders as well, who's an adult neurologist at St. V's. So the aims of the transition program is really to engage young people with SMA at a young age. We don't really want it to be a transfer process where it's you hit this age now, 18, you can't come to RCH because of the fact that you're not, a paediatric patient. So we want to give patients and families really enough time to learn and to grow and to develop and to understand what it's going to mean for them to leave this setting, which, they've grown to love and trust for such a long period of time, and to head off to a completely different setting. So we do this in some dedicated transition appointments, which are integrated into the normal neuromuscular clinic appointments. Next slide. So like I said before, it's about commencing early planning. And I'm just going to move my screen so I can see better. That's it. So it's just to commence some early planning and discussions. It's about education and development of knowledge of what SMA is and SMA medical treatments that each young person is having. Develop some self-care strategies if they're able to, and to transfer really that knowledge that the parents have, have been the one that's managed for all these years over to the young person. It's to support the young person with SMA and their parents in addressing other practical concerns around their education, if they're going to start employment, where they're going to live, the support that they have around them, and try and get that all sort of set in before they move over to the adult setting. Next slide. So I guess before we talk about sort of how we do it at RCH and what the practice is, I just wonder if we could just ask Dr. Epiu. I mean, I know this is something that we started in our practice probably about 5 years ago, but as a paediatric neurologist, what is something that you've experienced in your practice that that you've seen while we've had to put in such amazing had to put in these programs, and what's changed for you as being a paediatric neurologist with this condition?
Thanks, Jenny. That's a really excellent question. And I think if we just kind of think back to our model of care 15 years ago, before you started, we didn't have a multidisciplinary service. So around that time you came on board and we developed this great multidisciplinary clinic. And it really improved the way we did care for children with neuromuscular disorders in general, including patients with spinal muscular atrophy. And then along those lines, we started to see formal standards of care. And within there, they do talk a little bit about transition. And what we used to do was, it just kind of happened, we kind of realised that the child was either finishing school and or turning 18, and we would transition. The doctor would write a letter to an adult neurologist and they would just go. And there would be very little preparation, and we would often hear from the families afterwards that the process was not ideal, and we saw that we really needed to improve it. And this was a hospital-wide kind of process where this was happening across the board in multiple settings, particularly for children with chronic illnesses who'd been under a particular structure at the children's for a long time and then moving on to an adult service, which is quite different, as a lot of you know. So the things that have changed, so first of all, of course, for SMA have been the availability of therapies, which has really transformed how we talk to patients and children about what we expect for them with SMA. And we're seeing much improved survival, as you all know, improvements in function, improvement in strength. So we've really seen that we're able to transition more and more patients to the adult setting. We're able to adhere to standards of care, which of course ultimately improves long-term outcomes as well. And of course, respiratory support and improvements around that area, not so much in the last 5 years or so, but in general, have really improved outcomes for people with neuromuscular disorders. So you can see that there's multiple people involved in looking after these patients. And instead of the respiratory doctor sending a letter to the respiratory physician, the neurologist sending a letter to the neurologist, and then having this multidisciplinary team kind of suddenly disappear, we developed this with the transition team at the Children's, and I know Danny was very heavily involved with that from the outset. And I think it's a fantastic service because often, as you know, you're in the doctor's clinic with your appointment and you have various medical things that you need to go through, and there isn't always as much time to go through some of these things that Danny's listed here, you know, preparedness, adherence, becoming more independent for a child moving on to an adult transition phase. So I think it's really changed what we do, and I really think it's for the better. And I think, Danny, you're going to talk about this a little bit more.
Yeah. I think also interesting, Lauren, I'm keen to hear your point of view too, because as an adult neurologist, there was, you know, often these childhood illnesses and you probably didn't previously see a lot of them. And I wonder how your practice has changed now, given that we are transitioning. We're at that point now where you're receiving more and more of our neuromuscular patients into young adulthood.
You're exactly right. So many of these conditions used to be considered diseases of childhood, and they're now diseases beginning in childhood, and we're seeing people coming through and transitioning more and more. And you know, this concept of transition has been around for a while, and it's actually amazing how we still haven't quite got it right. And I mean, I very much have been for a long time on the end of that, here's your letter and that's it. And it was really interesting. A young man with Duchenne said to me, it's not very organised in the adult setting, is it? And I'm like, well, yeah, sorry about that, but you're right. Yeah. It is. And I think, you know, what's really changed for us in neuromuscular in the last couple of years, I think has been a lot more engagement with the Children's Hospital, and we kind of now know each other a little bit. I know you, you know me, and if something's not working, we know who to reach out to. And I think that's really important. And being able to say to people when I meet them for the first time, oh, yes, you were referred by Dr. Epi, and oh, yes, I know Danny. And it makes a difference when people think that you know where they've come from as well.
Yeah, absolutely. And that's the experience that we feel as well. So it was about 5 years ago that we did engage with the transition team of the hospital, and so we asked them about how other departments are doing it. And so we have put in a little practice into our clinic to support our patients in moving through. So the transition appointments are generally led by myself, and sometimes some of the transition team do come in to help. The appointments are structured using a checklist, and they're called health skills checklists, which I'll show you a little bit later. And so we structure it, and basically, each clinic is really led by what each young person and parents, where their level is at and what they want to discuss. So it's very individualised. Next. So this is one of the best case scenarios, and I think it occurred just before COVID. So obviously things did change for us through COVID, and we're excited to get back to that normal stage for us. But this was a young man who was about 16. I think he might have been a bit 16 and a half when we first started the transition process with him. He's fully dependent on a power wheelchair and lots of carers and his parents. As you can see, there is lots of other departments that work with him. So he had peg feed, so there was gastro and nutrition involved, lots of respiratory management. He would be a young man who'd often pop in to ICU for a short stay through winter with respiratory tract infections. So he was supported a lot with some BiPAP, cough assisted suction. He did have scoliosis surgery in his pre-teens, and it was a bit problematic for him. So he had a lot of orthopedic management. He did have a couple of fractures and was managed by endo, and he had his bisphosphonate treatments. Next slide. He did split his education into mainstream school and then special development education. He lived at home with his parents and his siblings, and they communicated that that was an amazing setup, and that's something where he wanted to remain through his adult life. He was very well supported with his parents. They attended all of his RCH appointments and managed all of his care. And around that time, he had also started some SMA treatments, some intrathecal treatments that we also managed at RCH. So I guess these are all the things we need to consider when we were going through this transition program. And now you can see why it's so important that we needed that real 2 years to work with the young person, his family, and RCH to get him ready to get the adult service to take on that care. Next slide. So this young boy or young man, I always call them kids when they come to clinic, and they're like, "No, I'm a young adult now." So, but his experience commenced, like I said, around 16 and a half in his clinic appointments. His initial discussions were held with him and his mum, and we used a health skills checklist to sort of structure our appointments. And I think the next slide, I've given an example of what the health skills checklist is. Awesome. So as you can see, this is quite a structured checklist, and we start off, we talk about, the young person's medical condition and their disability. So, and in this appointment, I would say, can you explain to me, why do you come to RCH? Tell me a little bit about your disability, what it means to you. And so, we would go on, and some people are able to really articulate what they have. Some kids are not, and so we would set some homework for him to come back and do it at the next clinic. I know that this specific health, just to answer a question quickly, this specific health skills checklist is really something that RCH has developed. It's open to other states, but other states do have other programs that they use, which are very, very similar. I think one's called Trampoline or something like that, but they are very similar across that country. So just moving quite along, because I know I'm running a bit short of time. Other things we talk about in the health skills checklist are, around medication. Tell us about your allergies. Who do you see at the hospital? Why do you see them? And then there are times when we would split the appointments. So, young person would sit with me, and the parent might sit with the neurologist for a period of time, and there's different things that the young person and the parent might want to discuss. Often when the young person is sitting alone with me, the things that they want to talk about are things that they don't want their parents to hear, and often, especially with boys, it'd be around sexual health, reproductive issues. When they go out with their mates, can they drink and smoke? What's going to happen to them? They wonder about, they know every part of their body is a muscle, and is all the muscles of the body weak? Can all the muscles work properly? So we do talk about sex, and we talk about the importance of exploring that. And then I always gain consent from them if they're happy for me to relay some of that information back on to their parents, so there's work that they can do together. So it's a lot more than just, who do you see at RCH, and then what do we need to set up for your adult service. Some young people aren't at that ability to take on independent care at all. And so, that's something where we would continue to work with the parent and the young person together at doing the best that the young person can, given their, learning and intellectual levels. Next slide. So these are just some of the other checklists that we use. So this is the one that we would use if the child is completely dependent on the parent's care. And then if you just click through, Robin, some of these other checklists around, as we start to get closer, we get the young person to just write down, you know, who you see at RCH, what do you need to see at the adult service, and a little introductory, like, how about you introduce yourself to the new neurologist? So, right, if you're a bit embarrassed to talk about it, write it down, write some notes, so that when you go to your first appointment, you're able to read as a little checklist about yourself, so that you can introduce yourself to the new service. I think, Robin, this is probably a really good time. I'd really like you to talk to us a little bit about some of the work that you do with our young people before they transition. You know, often some of these interesting questions come to me, but then I'm also able to refer to you for some insight about, you know, things like what happens if I want to have kids when I get a little bit older.
And I think the importance is that our team does work very closely together, and it's a privilege to be working with families at this time, because we've known many of the families since their child was a baby. So sometimes families are feeling a little bit uncomfortable about leaving the children's hospital, but also we're sometimes very sad to see them go as well, but very excited that they're going on to their next venture in their lives. And part of my conversation at the point of transition is about genetics and the whole family. So as Danny said, the young adult might ask about what are their options, you know, when they have children, can they have children in the future? So we'll talk a little bit about that, and about the possibility of being referred off to an IVF service in the future, if that's something that the person is interested in, prenatal testing, if that's something that they're interested in, the importance of their partners in the future, considering having carrier testing, but certainly that they will have options and choices in the future moving forward. And we also talk about how they can access adult genetic services. The other important role I think that I have at this point is also to discuss with families that siblings may wish to think about having carrier testing themselves in the future to see if they are carriers of SMA. We know that SMA is in the family, and how to access carrier testing and to make sure that they're having the right sort of testing for their family. And that may seem a little bit of an unusual thing to say, but there are a couple of different changes that can cause SMA, different genetic changes that can cause SMA. So we need to make sure that the family have the right information at the right time, and that the siblings are an important part of this process, and that they can contact me and speak with me independently with parents or without parents to get more information about this.
Thanks, Robin. Another kind of difficult conversation that sort of has come up since we've been doing this process is, you know, I do contact families about 6 months after the transfer has actually happened, just to get some feedback. It helps us be able to direct learnings in this program. And one of the things that popped up a few times was around, you know, advanced care planning. And I guess in a paediatric setting, and I'm sure if you can agree, you know, these are things that we don't really talk to our families about unless our patients are unwell or there's certain issues that have popped up. And so it's been interesting that families have said, at the appointments, they want to know all these things. Have we talked about what our wishes are for the future? And so, Lauren, I know that we've spoken about it before, but can you tell us a little bit about why that happens when when patients transition into the adult setting, and really what it's about, and I guess, you know, how we should better prepare our families when they're moving over?
So over the last couple of years in particular, there's been a big shift in adult medicine in general to include an increased emphasis on advanced care planning. And so we actually are expected to ask people when they come to hospital, do you have an advanced care plan? And we get audited on how often it's documented and how often we ask it. And so it's become a lot more at the front of our minds, and people tend to think about advanced care planning as oh, I'm dying, it's all about palliative care, but it's actually not. And when the conversations are had appropriately, it's actually another way for the clinician and the person with whatever condition they have to work better in a therapeutic relationship. And it's, for me, I see advanced care planning as a better way of understanding the hopes and needs and expectations of my patient, whether they're approaching end of life or not. And it means that if something dramatically happens, like a person with type 1 SMA who does need ventilatory support gets COVID, how much do I push our intensive care unit to intubate and do a whole lot of things? Or has this person said to me, you know what, I never want to be in ICU. I never want to have a breathing tube down my throat. And some people have never thought of that. But when the conversations have been had, it gives us a lot more power in advocating for what that person wants and what's important to their quality of life.
Yeah. Epi, do you start to think about those conversations now before
it's an interesting question, and Lauren, I'd be interested to know, when you bring up that conversation from the patients that we've transitioned, how often it is a surprise to them, because we might have that conversation with parents, whereas you're now dealing with that person. And I have to say, we probably don't always remember to, as children become a little bit more independent, become 15 or 16, to start to ask the young person their wishes.
I wouldn't have it in the first consultation unless that person was very severely unwell and I thought something might happen before the next consultation, because usually you want to build up a little bit of rapport first, because they're difficult conversations to have. So I'd usually leave it for a consultation or two. And also it would be dependent on how severe I thought the person's disease was and what risk I thought they had over the general population with regard to having an adverse outcome. I mean, anyone can go out and get hit by a bus. You don't really necessarily need advanced care planning around that. But it's got to be individualised. But I like to get to know people a little bit first if I can.
Yeah. And that's a lot of the conversations we have with the young people around, the letters are going to come to you, they're addressed to you now. When you meet the new medical team and allied health team, they'll look at you. You need to be able to speak up and talk about what you're feeling, where a lot of the time now we always do direct the conversations to parents. So we try and do some role playing. I send them into the neurologist's office by themselves, or mum and dad sit at the back. So we do try and do a bit of that role playing before we get over. Yeah.
And we set that up as well. I mean, I've only ever had one young adult come to their first consultation without mum and or dad. But I will then usually set up in the first consultation, next time you might want to come by yourself. And that's what it's like in an adult neurology and those sort of things. And you help them bridge that gap as well.
Yeah.
The other thing that I guess, Danny, we have at our hospital with our electronic medical record is that at the age of 16, there is it's got a patient portal, and at 16 years of age, the young person gets control of their portal, and the patients will come in, or the parents will come in, and they'll say, I can't get into the portal anymore. I said, that's because they've turned 16. They have to give you permission to access their portal through this. And that's just for our hospital. I don't know how it is in other centres.
Yeah. And that brings up that whole topic of consents, which is great that we can start thinking about. The last slide just really talked about this young man's experience in the final year. So in the final year of the transition program, we do set up like a telehealth appointment with the adult service, and it's really catered on all of their needs. So in that appointment, we would have in this young man's appointment, we had respiratory, neurology, orthopedics, and there was someone from gastro present. And so we would do, say, a 15-minute presentation to them, so just medical teams, about the medical part of this patient. And then we would invite the family in to talk about themselves, the young man to talk about himself. And he certainly felt comfortable, which was great. He was able to talk about all his needs and things he likes and doesn't like. And he talked about what he was going to do in the following year. He's going to do some vocational stuff, and he talked about his footy team, and so a bit of a get to know you. The adult service set up some appointments for him, but we still keep them at RCH So there's kind of like dual care for about a year, just to make sure that everything's linked in, and then we see them and they tell us that they couldn't find a car park and they had to wait in the waiting room for ages, and they couldn't forget, they could remember who the doctor's name was and all this crazy stuff. And then we do our final appointment, which is the transfer, once we know that they're sort of set up in the adult service. And I guess it's, important to say that this is the best case. There's lots of limitations on, why not every patient's experience is like this. And, it's something that we all work really, really hard to make sure that everyone has the best experience possible. Yeah.
Parking's a nightmare. The biggest complaint I have is the parking.
And the wait time. But, I mean, our wait time's not great either. So, but it's all okay, I guess. And I think, the other thing is, we're really trying to make our parents and families and patients aware that the adult services don't have a multidisciplinary service like us. It's not a one-stop shop. And so that's why we do this. This is why it's really important that you know who's looking after you and why you need to see a neurologist, why you need to see a respiratory, even though things are running along fine, why it's important to see certain specialties, because you might need to chase them. It's like at RCH, we chase you. And if you're in a service which is not together as one, it's very easy to get lost.
And we just don't have the resources to be chasing people when they don't turn up often, unless it's been flagged with. There's sometimes if an appointment's been rescheduled or cancelled, we don't know. And so we may not necessarily know that a person's missed their appointment. And I think too, just around the multidisciplinary clinic, part of the reason that it doesn't happen is historical, in that a lot of the specialties traditionally have their own days where they have their clinics. So neuromuscular clinic at St. Vincent's has always been on a Thursday afternoon, but metabolic bone health is a Friday morning. And so trying to bring people together when it's not their day, and then it's the physical space. We could run so many more clinics, but we physically don't have the space to run more clinics at the same time. So sometimes it's those logistic things. The medicine's easy, it's the logistics that are hard.
Yeah.
And funding, I guess, for allied health in a multidisciplinary setting. Yeah.
Or for nursing. So
Correct.
I actually don't know of any adult neuromuscular nurses in Australia. I think there's one or two, but we certainly don't have one. We are working with Muscular Dystrophy Australia at the moment to get together a research project to pilot defining the role, and hoping that that'll be a shared position between the Austin and St. Vincent's, so that we can actually test the role, describe it, define it, work out what works and what doesn't, and that hopefully will be a model that can be rolled out across Australia. But it does come down to funding.
Yeah, absolutely. So we might open it up to audience questions. Robin, maybe you might be best to facilitate this because you're on site.
Thanks, Danny. So please, if there's any questions for any of us on the team, please just pop them through and we can read them out.
And also, one of the things in preparing for today that we've been chatting about is, maybe say for St. Vincent's, it might be worth us having a webinar once or twice a year where we invite people who are about to transition and to say, well, I'm Lauren, I'm one of the neurologists, and, this is Dr. David Pryor, he's the cardiologist, and this is Dr. Santa Maria, he'll help look after your lungs, and this is Kerry, she's our physio. And whether that would be helpful or not, like, this is where the building is, here's how to get here, here's the easiest parking. So I'm interested, even if people just put a couple of comments in the chat, is that something you think would have been helpful for you when you had your transition? Do you want resources on our websites? What would work? Now's your opportunity to tell us what would be helpful, as much as to ask some questions.
I think that's really important, Lauren, because we put together what we think is going to, and what parents want and what young people want. But it's only when I've called parents back like 6 months later that they've identified all these issues that I haven't even thought about. And because I'm not living that experience, and, what we've not done right to families. And we can only improve our service from knowing what young people and their families need and want. So that's a really good point. So adults with SMA.
And that's important. You know, we can't fix things if we don't know it's a problem.
Absolutely.
People can also pop their hands up and we can then go live to you as well if that's an option for people.
And it was interesting out of the focus groups, people saying going to new facilities and not knowing where the accessible toilets are. I had to think of like, oh, do I know where they are in my building? I actually did a walkthrough of my entire 5-level building where outpatients is at St. Bees last week to check, because I know we don't have an ambulatory or accessible toilet on our floor. Are you guys ready for me to record? No? Okay. So I walked down and we have 3, and the one on level 3, which is supposedly an accessible toilet, the door is so heavy I could hardly open it. And you've got to go through a narrow doorway and go round this like 90-degree angle corner, and there's a table in the way, so you couldn't even get through. So, you know, it was all of those little things. I think when you're going to a new place and you don't even know where the toilet is and you get to the toilet and it doesn't work properly or you can't get in there, you know, all of those little things can make that transition really stressful that we don't know unless we're thinking about them explicitly.
Mm-hmm.
I guess while we're waiting for questions, I guess we're always open on our end for young people and parents to tell us, can we talk about this? I'm transitioning soon. What should I do? Can we, you know, because it might not always come up in the appointment. We're always very happy to have things flagged with us early if there are any specific things, again, that we haven't thought of. So. The other thing, Lauren, I was just listening to your excellent session before about, you know, the question about NDIS and access and the difficulties. It's something we've been talking about in our team as well, is that how can it be so difficult sometimes to prove that you have a lifelong condition that is degenerative in a sense. So perhaps it's something we can talk offline about.
Yeah,
because we've been thinking about how to improve that as well.
It's a great idea from Ellie that, you know, I mean, we've pulled together so much information, and now we are, as a SMA community, we're partnering so much better. We're working together so much more. You know, adults, pediatrics, people living with the condition, industry. It's a lot more powerful collaboration, and we may as well leverage off it.
Yeah, and I think it's really important to have NDIS set up before you know, everything kind of course, every year you have to prove yourself again, but at least set up as best as you can to make at least that transition part a bit easier. Because you know, it seems like there is a lot more dependence on NDIS allied health as opposed to having an overseeing consultative service that we do have in our clinic, because it's multidisciplinary. So I must
say the thing that's great about NDIS when you get it is being able to have clinicians and health professionals come to your home. So your physio can come and work with you in your home environment. I think that's actually one of the best things once you get it sorted, is being able to actually say, no, I need this and I need this in my home environment, and I need this person to help me in this way. Which is why I think, you know, when talking about, you know, that access to expertise as well, one of the other things that we've been toying with the idea is having like a centre of excellence around physiotherapy, where we can set up education so that the community physios can then go to this website or resource access or whatever, and then your local physios can upskill to the individual.
We have had that model, Lauren, so yeah, we should talk after this perhaps. Yeah.
Robin, do you want to, there's a couple of hands.
Ellie has a question for us.
Yeah, thank you. Just what you were saying, Lauren, in having specialists coming to the home. I know I would benefit from physiotherapy a lot. I've been told by my doctor, and I feel it when I do move around. It makes me feel a lot better. It keeps my joints lubricated, and but it's so hard to find a physiotherapist that can make house calls. I haven't found any. I've been told by other people that, they do it, but I don't know of any, I don't know where to look. So, yeah.
So that's the other resource we need is, okay, I live in this area, I need this. Who is the expert for me?
Mm-hmm. And this is where parent groups can be really important too, at pulling these resources together for patients.
It's Francesca here. I'm Micheline's sister and sister of also Jude and Jeanette. And I'm just wondering, I think it's fantastic that you're all sort of now involved and interested in everything else, but there are many specialists out there that know very little still about spinal muscular atrophy and how the questions to ask. And I know that you've got now preparing that have a questionnaire, but how are you going to share that information more and more with other people and physio and all that? Sort of what do you think we should be doing as an organization and for yourselves as well to sort of increase the awareness?
Yeah, Francesca, that's really important. I mean, there's actually only 700 odd neurologists in Australia. So it's actually not a huge number of neurologists. And within that, everybody has their own little niche areas, like they might do movement disorders or specialists. So the group within that specializes in neuromuscular is even smaller. So trying to get not just the information out to the people who are the specialists in the field, but then the subspecialists and then the general practitioners and everybody, it's a real big challenge. And so, as you say, the consensus statement's going to be at least a first step in this direction, because you're going to be able to Google SMA management. It's going to come up and there's going to be something that's been put together by experts. I think the next thing is actually the one good thing about COVID is that we've had so much more access to online education. There's so much more awareness about webinars and this kind of thing. So we can do online education with a much broader reach to other health professionals now, and certainly plans around that are coming forward. I think it's been great engaging with the webinars with SMA Australia and having some more interaction in that way, leveraging off social media. There's a whole lot of ways to go about that. And I think getting some, expert-derived resources available and readily available. There's a new website that Ian Woodcock has led, and I know there'll be some adult information coming onto that. I'm supposed to be writing the Duchenne stuff, which I haven't done, so sorry to anyone who knows anyone with Duchenne, that's my bad. But getting it all out there, getting it onto the internet, onto webinars, and using social media platforms, working together. Industry have a role here as well. Most industry have a specification around health professional education, and they're out there in the hospitals, they're out there in the practices engaging with clinicians. And I think for us as clinicians, making sure that our industry partners have clinician-informed information and not just industry-formed information is important as well. Sorry, I hijacked the question answer there.
No, thank you. I'm also on the board of Cabrini. And so to the extent that there is anything that, like if you need access to a craft group or you'd like something in that context, very happy to sort of provide that entree, but I'm sure you already have entrees there, but to the extent there's anything.
Yeah, that's great to know that the networking becomes even more important in this context when you're talking about rare diseases.
Yeah. Because we do also have a research group that looks at things as well. Okay.
And I think you alluded to an important point there, Lauren, that networking is incredibly important. So the more that we network with our peers and other health professionals as well, and I know that Lauren has a couple of posters at the upcoming ANZAN meeting, and the registry as a poster at the ANZAN meeting. These have been on hold for the last couple of years. So bringing back the face-to-face meetings, us advocating with SMA Australia and presenting at meetings like this as well. I know we're talking to the conversion, and it gets out more and more.
There's just a question here in the chat section about treatments now available for adults. Has there been any consideration given to the transition of adults back into the hospital system after being disconnected for many years?
Yeah, that's something I'm really passionate about, is finding adults who've had the experience of, this doesn't work for me, this is not worth my while, there's no point me going to this consultation because all the doctor says is, oh yeah, you're getting worse, off you go. There's so much we can do now, so we really do need to try and bring people back. And I wonder, it's actually a really good comment because I wonder whether we need to be then actually going back to the paediatric hospitals and going, can we double check your lists? Who did you transition 10 years ago that's fallen off our radar? I mean, a lot of hospitals, we don't have that kind of record, so we actually can't do that. So it's a game where really it comes down to, I think, awareness in the community, and social media is a great way to say treatment out there, go find a neurologist, and the next step's got to be there, and here's how you do that. Yeah.
And I have to fly the nursing flag a little bit here, Lauren. I think this is where it's really important to have the coordinating champions on both ends, paediatric and adult service, that really make sure that that young people and then adults are staying engaged. And it's an excellent role for a nurse to coordinate and manage, and it's a really important service that needs to be at both centres.
So, Robin, as a genetics counsellor, how close are we to cloning Danny? Because I would like one.
Possibly not in my lifetime, Lauren.
Oh, you never know. We didn't think we'd have a treatment for SMA in our lifetime. Anything's possible.
Right. That's exactly right. Bright minds like yours.
But I think we would equally be having the same conversations with MDA, and I think we both share that passion. And that'll be some work that I'll be working with them as well. Yeah, absolutely. Yeah. Is there any other questions before we close up this session?
I'm sitting in the background just listening, stay there. I'm just listening to all the comments, and I guess we can all be champions in, getting people across the line back into treatment. If you know somebody, reach out to them.
Absolutely.
It's not hard. You might have a friend that you know that ask the question, have you seen a neurologist recently? How can we help you be connected? It all comes down to us in the end. You may know somebody out there that you're not connected with, or you are connected with, and they know somebody who you're not connected with, and the triangle just keeps going. So we can all be champions in our own right. Don't rely on the Robin Forbes or the Danny Villanos of this world. Take it upon yourself to open this or start the conversation about accessing those treatments. Get them in touch with the Laurens or the other neurologists, and we can then find these, rabbit warrens, open them up and get these people accessing, treatment. So, that would be sort of my message as well. We have a part to play in this.
It's not a difficult process. You get a referral to your GP and you're in. Like it's really quite easy.
It is. So we all have a part to play, and, reach out, think of somebody else instead of yourself once, and go out there and ask the question. It's really important, and it may make a difference in somebody's life today, tomorrow, or 5 minutes down the track. So it's great to start that conversation for sure.
It's a very good point, Julie.
Yeah.